This array represents a standard student population. These highlighted icons represent the 4% of U.S. youth meeting the criteria for conduct disorder, defined by a repetitive, persistent pattern of behavior violating others' rights and major societal norms. A formal diagnosis requires exhibiting 3 or more of 15 clinical criteria over a 12-month period. These fall into 4 pillars: aggression, property destruction, deceitfulness or theft, and serious rules violations. Clinical outcomes vary based on onset. Childhood cases, emerging before age 10, carry a statistically worse prognosis than those originating in adolescence. This compounding downward trajectory indicates early onset symptoms require specialized clinical intervention, not standard disciplinary tracking. When this specific neurobehavioral pattern is categorized as a simple disciplinary issue, it creates a fundamental mismatch between the student's clinical needs and the school's response. The standard administrative response to serious infractions relies heavily on exclusionary tactics, suspensions, expulsions, and confrontational boot camps. Clinical data suggests a high risk in this approach. Relying on confrontational and exclusionary models is often counterproductive to long-term behavioral modification. On this outcome flowchart, punitive models and scared straight programs actually increase delinquency rates. This feedback loop is driven by isolation. Exclusion disconnects the student from stabilizing social structures, leading right back to the behaviors triggering the punishment. While administrators use punishment as a deterrent, the clinical record shows that for students with conduct disorder, these measures correlate with an acceleration of symptoms. When exclusionary punishment is applied to a clinical diagnostic pattern, the data suggests the behavior is more likely to intensify than to resolve. Aggression and destruction operate as a surface signal, indicating intense, unseen pressure below the level of the behavior. In many cases, untreated trauma serves as the primary driver of these conduct problems. That trauma often exists alongside other hidden factors, including undiagnosed ADHD, language and learning disorders, family system strain, or substance use. Because these underlying drivers dictate the outward actions, a trauma-informed assessment becomes the necessary baseline for determining any effective intervention. If these root causes remain unidentified, the resulting administrative response will likely fail to address the actual source of the behavior. Behavioral correction relies on treating this root etiology, rather than merely suppressing the surface symptom. The evidence-based solution for conduct disorder is family-based. It requires multisystemic clinical interventions that treat the student within their environment. The core of this framework is multisystemic therapy, or MST. This approach targets and stabilizes with students' entire operating environment. This is frequently paired with functional family therapy to address the family system strains that contribute to the disorder. Multidimensional treatment foster care and structured parent management training complete this clinical architecture. These interventions are effective because they reinforce the student's support network instead of severing their ties to it. For these modalities to succeed, they require active care coordination across the medical provider, the family, and the school system. Behavioral correction is a systemic challenge that requires a multinodal clinical network to solve. Integrating these clinical networks presents a logistical hurdle for Georgia districts. They need a way to deploy these interventions without overhauling their existing infrastructure. The MentalSpace school model serves as an operational bridge. Their teletherapy framework synchronizes directly with student support teams, juvenile justice, and family services. Deployment is handled through same-day teletherapy and dedicated therapist teams assigned to each school to coordinate care with counselors and prescribers. This structure allows the 4% of students meeting CD criteria to receive continuous, culturally competent clinical care. The data from districts transitioning to this model shows significant improvement across several key metrics. This includes an 89% improvement in student attendance. Districts also report a 92% reduction in student anxiety and an 85% family satisfaction rate. Districts that replace suspension-first policies with integrated clinical support see a measurable shift in the behavioral outcomes and school engagement of this For Medicaid-eligible students, the cost is $0. The model is also supported by major commercial carriers, including Aetna, Cigna, and Blue Cross Blue Shield. On the data side, the platform maintains strict HIPAA and FERPA compliance standards. There is also a legislative deadline approaching. Georgia schools must meet HB 268 compliance requirements by July 2026. Adopting the MentalSpace model provides districts with a direct path to meeting these upcoming state requirements. Schools are faced with a choice: continue with exclusionary punishment or adopt a clinical support system backed by evidence. Moving forward requires shifting away from systemic exclusion and toward integrated clinical support networks within the school environment. Behavioral correction is not achieved by pushing a student out of the system, but by